Good day, ladies and gentlemen. My names are Dr. Kurfi Abubakar Muhammad, a public health physician based in Nigeria. My area of interest are health system strengthening and healthcare financing in low-income nations. I'll be speaking to you about the challenges of coordinating the multiple donors and implementing partners working on HIV/AIDS in Nigeria. Nigeria is a country located in West Africa, whose rough population is 166 million. It negatively contributes 10 to 15% of global HIV/AIDS burden. It also contributes 32% of the global PMTCT gap and 20% of global new HIV/AIDS infections. There are currently 3.3 million Nigerians living with HIV and AIDS, out of which 1.5 million are in need of antiretroviral RT, but only 500,000 have access to these life-saving medications. The national HIV/AIDS prevalence is currently 4.1%, according to the ANC Sero Prevalence Survey. It was as high as 5.8 in 2001, before declining somewhat gradually to the present level of 4.1. The concern, however, is that if more people are placed on antiretroviral therapy, theoretically, which means they are living longer, and we are contributing the highest number of new infections globally, then how come our prevalence is going down? After all, prevalence is supposed to be the number of old and new cases of a disease at any given point in time. This is the HIV/AIDS implementation landscape in the country. Numerous donors, numerous implementing partners, all working in a somewhat uncoordinated fashion to curtail the epidemic. This has led to multiplicity of plans, guidelines, policies and indicators and frameworks, leading to a very chaotic scenario whereby the overall concomitant effect of all this multiplicity of donors working on this response is that as they do more, less is seen to be the result. One of the major drawbacks of this lack of coordination is the issue of unclear leadership, where there is no single body with the authority to convene all donors and compel them to comply with national guidelines and policies. Among donor agencies implementing partners too, there is no single leadership. Each operates as a mini king in his own domain. The National Agency for Control of AIDS, NACA, which is supposed to be responsible for the multi-sector response, has heavy administrative weaknesses that make it not to be able to effectively carry out this function. In addition, there are other agencies like NASCAP, which is to coordinate the health sector response, and the synergy between the two is somehow also not there. Another challenge is the issue of duplication of efforts. Many donors and implementing partners working in the country often focus on the same needs. They have the same needs and place more emphasis on quantifiable programs where results can easily be shown, rather than, for example, health system strengthening, where you cannot show results easily. In addition, donors tend to focus more on high prevalence states where data can be easily generated. All these and many more have led to overlap of functions and duplication of efforts among donor agencies and implementing partners, therefore undermining the cost effectiveness of the response in the long run. Unhealthy competition. Numerous donors have their activities conflicting and overlapping, undermining the same developmental objective they set out to achieve initially, because they compete for the same materials, the same human resources, and other limited resources too. In addition, their trend towards supporting higher value, easily quantifiable projects dilutes the overall impact of the AIDS and threatens the activities that may require donors to come together, pull their resources together, and execute jointly. There is also a universal lack of programmatic information sharing from and across donors and from donor organization to the country itself. This contributes in no small way to the deficiency of integrity and reliability of our national data. It is also responsible for the inability of the country to sit together on the same table with donor organizations to work towards developing a harmonious work plan and a unified agenda for implementing activities collectively so that we can be able to curtail this menace. The presence of these donor agencies also has shown that there is really no any verifiable empirical evidence that their presence actually has translated into better coverage or improvement in HIV/AIDS service delivery. As Nigeria still continues to lead the way in contributing to new infections, more and more pediatric HIV deaths, and global PMTCT gap among others. What however is certain is that the multiplicity of these partners means more administrative demands on the part of the government in order to meet the multiple oversight requirements. As can be seen from this chart, 24.5% of the cumulative annual HIV/AIDS expenditure goes to program management, another 19.3% goes to human resources, while another 4.4% goes to creating enabling environment, whatever that means. As a result, almost 50% of the HIV/AIDS annual expenditure does not go into direct service provision. This is not good use of resources from economic point of view. If one compares with other African nations who spend on the average 10 to 15% of their resources on program support, as shown in this chart. Another major challenge we face is the issue of obvious over-dependency on donor agencies. As can be seen from this chart, which shows that 75% of the national HIV/AIDS expenditure actually came from donor agencies based outside the country. This dependency on foreign sources of funding will continue to rise, as shown in this chart, which shows that in year 2014 alone, Nigeria will require about $1.1 billion to sustain and scale up the HIV/AIDS response in the country. And in this same year, it will have a gap of about $500 million. The obvious anticipation, of course, is that foreign organizations will still come and fill this spot. For a country like Nigeria, with its huge material and human resources, this is not only unacceptable but ridiculous, especially with the clamor for aid freeze globally and the current global economic meltdown, which has led to the decline in foreign direct investments across all over the world. There is therefore need for Nigeria to devise innovative mechanisms to expand the fiscal space by harnessing maximum private sector participation in HIV/AIDS service delivery in the country. In addition, implementing partners and donor agencies working in Nigeria must respect global declarations like the Paris Declaration, as I'm showing here, and the Accra Accord for Action, so as to ensure harmony, complementarity, and universal alignment of their activities to the national plans and guidelines. In conclusion, Nigeria must also, as a nation, demonstrate better accountability to donor funds and show more political commitment and ownership of this response if our dream of ending AIDS is to be made realistic. 3 keywords stand out: sustainability, ownership, and mutual accountability if we must reach zero. Thank you so much. I can be reached on abukurfi@gmail.com, or you can follow me on Twitter at abukurfi. Thank you.